Thank you so much. I'm delighted to be here, and I'm really very, very honored to have a panel as stellar as this, really a global stature panel with stakeholders that have flown from far away, and we're very, very, very happy to have you with us. But also with one of our key representatives from both clinical side and government side. For these two very exciting programs. So my name is Lawrence. I'm a cancer molecular biologist by background, and cancer is a very special theme for me. But actually, cancer is a very special theme for all of us. And my father-in-law was diagnosed with prostate cancer, for example, in his bones. And the year before, he had none. Yet he passed his tests, and the year after, he had stage 4 cancer. And I thought that I'd use this as a start, because if I ask you to go through your friends and families, you will very soon realize that this story is not a very rare one. You know, we all have such stories. And it's dramatic because, again, as a cancer biologist, I look back at how cancer biology has advanced over the last 50 years. And if I ask you as subject matter experts, think of cancer biology 50 years ago and think about it now, you'd laugh. But how much has that managed to impact our ability to identify this global threat early? Actually, a question that's very related to our panel today. And it's related to our panel because it's related to screening. So the key word in our discussion here, and much of the presentations that M42 has done to date in Abu Dhabi Health for these 4 days, is around prevention and screening. In this case, we're talking about liquid biopsy screening, which is a technology that is reasonably new and promises to transform these inefficiencies in early cancer detection. I'm grateful to Amandeep for mentioning our 2 collaboration agreements that were signed today with the representatives of the companies, in fact, the leaders of the companies that are here with us. And I'll just extend again my sincere thanks for your presence today. The burden for this is rising. Although we understand biology more, a lot of this is not changing. People don't like screening. Still, people, including myself, we're considering screening as a nice to have and not as a must have. And people are dying. So I think I'll just start questions, Dr. Budoor, from yourself as a key stakeholder from Abu Dhabi Public Health Center in the design and deployment of our colorectal cancer liquid biopsy program with the Garden Shield product. If you can tell us a bit more about the screening program that Abu Dhabi refers to as IFHAS, the comprehensive screening program that's called IFHAS, and just give us an overview and explain this program. Thank you.
Thank you, first of all, for inviting us to this wonderful panel discussion under M42. Actually, when we start talking about IFHAS, it's an Arabic name for go for testing. So we are advising people to go for testing. So IFHAS, it's actually an integrated, comprehensive screening program to detect different priorities of non-communicable diseases in order to contribute to reduce the burden of those type of chronic diseases, including also cancer. So basically our target population for going to do IFHAS, those population age 18 years to 75 years of age who has or hold a Thiqa insurance card within the Emirates of Abu Dhabi. And our aim by implementing these type of comprehensive screening programs for, as you mentioned, Dr. Lawrence, is early detection of those non-communicable diseases that are common within our society. But we are, of course, implementing this on a healthy asymptomatic population in order to eventually reduce the burden of those type of chronic diseases. Mainly the scope of this comprehensive screening program is an integrated assessment of your health risk for those diseases, including what I mentioned earlier, but through having a general comprehensive questionnaire, health questionnaire, plus a comprehensive screening clinical examination. We have different type of packages, test packages, depending on age and sex. And the person has to do it on regular basis. The blood test has to be repeated every 3 years. But the other types of screening, for example, the cancer screening, it will be done depending on the age and gender. If we take an example of, for example, breast cancer screening, if the lady, for example, reach 40 years of age, she will have a mammogram every 2 years. For males and females also reaching 40 years of age, to do colon cancer screening, they have to go for fecal occult blood fit test every 1 year, every year, or for example, colonoscopy every 10 years. And now we are introducing the advanced liquid biopsy. They have to do it every 3 years as per our current criteria. So basically, our target populations will be going through different screening programs. It will cover different type of cardiovascular risk factors, including diabetes, obesity, and hypertension, oral health, mental health, top priority cancers, including breast cancer, cervical cancer, lung and colorectal cancer, and also vision and hearing for elderly people, and mental health, and also musculoskeletal diseases with DISCA scan also for osteoporosis. We have within Abu Dhabi 6 main healthcare providers who are offering the comprehensive screening program FHAS, and currently we are completed our initial pilot phase on 2023 with 94% of completion rate for people who underwent the blood test and 86% satisfaction from the patient side. This is an overview about the comprehensive screening program FHAS. And currently we are introducing, as we mentioned, the liquid biopsy as part of the colorectal cancer screening under FHAS.
That's an amazing answer, Dr. Budoor. Thank you, because you really gave this very broad spectrum of effort. And within our focus today, we have 2 particular use cases, but it's really fantastic to see the breadth of the work and the sort of organization. I'd like to just travel now into the clinic with my question to Dr. Ammar Khair, who's a friend and a leader that's really inputted much into this colorectal cancer screening program, which is the global first, by the way. We need to stress that. Dr. Ammar, you head the colorectal cancer screening program from the Cleveland Clinic Abu Dhabi side. Give us the reality of what that means in terms of numbers and how you see room for improvement. Where would you like this to move?
Thank you, Lawrence, for the invitation and for M42 for hosting us. So colon cancer screening is a priority not just for the UAE, but globally. Every year we diagnose about 2 million cases with colon cancer, and about 1 million of them die because of the late diagnosis of colon cancer. In the UAE, it's a health issue where we have colon cancer is the #1 leading cancer in men and #3 in women. And it's the leading cause of cancer mortality in the UAE. Now, we have different ways to screen for colon cancer, as Dr. Budoor mentioned, colonoscopy, for example, or stool testing. But the issue we have is the compliance and the uptake of screening. So globally and in the UAE, we have a very low uptake for colon cancer screening, even though colon cancer, in my opinion, is completely preventable. You get a polyp, that polyp grows as a benign lesion for 8 to 10 years before it becomes a cancer. So it doesn't come out of the blue. So you have a benign polyp. If you remove it effectively, you actually can prevent cancer 100%. So that 8 to 10 years give us an opportunity for screening. But the reality is we have a very low uptake. Colonoscopy, even though it's the best test, but the uptake is low because it's inconvenient. People perceive it as an invasive testing. It's also inconvenient for taking a day off. You have to take bowel prep. A lot of issues that makes it culturally and in real world very challenging to do. The stool test, on the other hand, also the uptake is very low. So that leaves us a very big gap in colon cancer adherence. And it is exciting times for us to have the liquid biopsy, especially in Abu Dhabi as a leading state and a leading city. And we are fortunate at Cleveland Clinic Abu Dhabi to be working with different stakeholders to hopefully make an impact and save lives. And the reality is most of these cases come very late when they're diagnosed with colon cancer. And keep in mind, if you are screened and diagnosed early, 90% of cases can be saved. But the reality is we lose a lot of lives every year for colon cancer.
90% of patients can be saved. That's could be the title of the presentation actually today. Yeah. Thank you. I'll move to our industry partners that we're very proud to have here with us. And maybe I'll start, Dr. Amir, with welcoming yourself, sir, and thanking you for your presence. Give us an overview of the Guardant Health journey to date, what this program means for you. And I want to just stress, this is the first FDA-approved liquid biopsy for primary screening that's out there. So in the context of our discussion, we have that really Abu Dhabi first, very much real Abu Dhabi first victory. So I'll pass to you, Dr. Amir, please, for your reflections.
Yeah, thank you very much to be part of this event and this conversation. So we are very excited of what actually we've been able to do, not just as a company, but as a whole field. This field of liquid biopsy, blood testing for a field of oncology has been under active investigation at least for the last 60 years. And now, when we just look at what's happening, like we are testing about 25 to 30% of all advanced cancer patients in the United States and over 50 countries globally for their treatment management. We are providing additional insight to physician, patient, that they get actually the treatment which are gonna be more effective for them. We made a blood test, Guardant Reveal, for managing cancer survivors, like colorectal cancer patient who go through surgical resection. They want to know if there is any residual disease left in them or not. We have a blood test for that. And most recently, we are very excited that now we have FDA approval for the first blood test for colon cancer screening as a primary choice for patients. It's a test that can detect cancers at early stages, even what we've shown in our pivotal study. As long as cancer is at stage 2, we are detecting all of them. Vast majority of early stage cancers are getting detected. And these are the cases that you can have long-term survival for a very high percentage of the patient. So this convenient, pleasant blood test that can get routinely integrated into the workup of the patients when they see their physician is something which really has a high potential in increasing the overall compliance to cancer screening. We are very excited with this partnership with DOH. They are really acting as a leading partner to thinking about how could we have population-wide screening program. And I predict within the next few years, based on the hopefully success that we are going to see more and more governments try to replicate what some leaders at DOH are doing today.
Thank you so much for that lovely answer. I'll move to Dave. Please, Dave. Moving to Dave means we're shifting from the colorectal cancer space, in this case, to pancreatic cancer, which, as Dave will tell us, is one of the most mortal cancers out there, and one where finding things early is maximally important and impactful. So Dave, maybe for comments on your journey and the importance of the technology from your perspective. Thank you.
Thank you again to M42 and Lawrence for the invitation today. As Dr. Amir Ali said, there's been a lot of innovation in liquid biopsy over the years, and the time is now to be able to apply this in a clinical setting. The question is, how do we go about doing it, and what type of clinical challenge are we trying to address? At ClearNote, we've decided to focus applying the blood-based and DNA-based liquid biopsy technology to the most deadly cancers that there are no screening options for. Pancreatic cancer is one of those, where 87% of patients with pancreatic cancer are diagnosed at stage 3 and stage 4, when treatment options are very, very limited. So the whole concept is, how can we detect cancer at stage 1 or even stage 2 when the treatment options are much more plentiful, and in many cases with surgical resection, a cure could be possible. So we've decided to focus on pancreatic and also ovarian cancer, another cancer detected very late, but we'll just talk about pancreatic cancer more specifically. The other approach is, since these cancers are still relatively rare, although extremely deadly, the question is, how do you go about testing patients who are most relevant for developing these cancers? So our approach is, instead of testing everyone over the age of 45, we're focusing in on the patients that are at the very highest risk for developing pancreatic cancer. So it's a more narrow targeted group. And one of the top risk factors where you have up to an 800% higher risk for developing pancreatic cancer is a recent diagnosis of type 2 diabetes. Type 2 diabetes in incidence is growing globally. It's over 20% here in the UAE. And over 25% of all patients diagnosed with pancreatic cancer each year have just had a recent diagnosis of type 2 diabetes. So that's an example of one of the risk factors. Family history and genetic predisposition, having certain mutations, elevate your risk for developing pancreatic cancer. So that's where we'll start offering the test, work with our partners here at M42 and Department of Health and many of the healthcare providers here to help ensure that those patients at the greatest risk for developing one of the most deadly cancers have a blood-based option to surveil and ensure that we catch it early when their life can be saved.
That's great, Dave. Thanks. A comment here, what Dave talked about is the connection, the unfortunate connection between new onset diabetes and pancreatic cancer. And this is what makes this collaboration for us and M42 and here in Abu Dhabi, where the regulatory partner is really, really exciting because unfortunately we have, of course, as everybody knows, not only here but in the region, extremely high prevalence of diabetes. So Imperial College London Diabetes Center, which is the core M42 clinical asset, is very central to this collaboration for us, along with Cleveland Clinic Abu Dhabi. Thank you, Dave. I'll come to you, Dr. Shiva, as the chief of the GI environment in CCAD. Dr. Shiva is one of these clinicians and one of these people that are just, as Dr. Umar, constantly kind, constantly giving, constantly supportive. And we wouldn't have been able to design this global first colorectal cancer liquid biopsy program without these two gentlemen. So we're extremely grateful for that. Dr. Shiva, I wanted to just take you out of the test and out of the technology for now as a start, and just ask you to comment on how you've seen the process of designing this more broadly as a clinician, but also from a policy perspective and everything that we've gone through together, if you wish, that has the test as its center, but many, many more very important components around it. Please, sir.
So thank you, Lawrence, and M42 for the invitation. And, I'd like to say at the outset that, for us as clinicians, we know that cancer screening saves lives. As simple as that. And the best test is the test that the patient will do. Not an ideal test, but the test that the patient will do. For us at Cleveland Clinic, myself and Amar, we see patients that would have benefited from screening who we diagnose often at advanced stages. So we have always believed in offering the most innovative solutions to our patients, including in the domain of screening. And for us, we are truly fortunate to have two partners in M42 that drives innovation and has been, really a driving force behind conceiving and conceptualizing and executing this project, and a regulator and a supporter in the Department of Health and Abu Dhabi Public Health Center. We couldn't have been more fortunate to have two stakeholders that have worked with us to develop this project. I think it's worth noting, it's remarkable that within 6 months of the FDA approving a liquid biopsy-based colorectal cancer screening project, here we are offering it not in the clinic to individual patients, but on a more larger population scale. I think it's remarkable. We are fortunate to be a part of this journey, and I think it's going to serve our patients. Following up on what Ammar said, we do have effective screening options for colorectal cancer. Unfortunately, colonoscopy is often perceived as being invasive, and the FIT test, the stool-based test, the uptake is very low. So we are left with a large cohort of unscreened patients. And as I said, we always have to remind ourselves the best screening test is what the patient's going to do. Talking about pancreatic cancer, we just don't have effective screening options. We struggle. It's a disease that's often diagnosed at a later stage, albeit the disease burden being lower than colorectal cancer. But to be able to offer these innovative solutions in the screening domain to our patients, brings a lot of satisfaction to us as clinicians, and we are truly grateful for the opportunity to collaborate with M42, DOH, and our industry partners to execute this population-based project, and I think the results will speak for themselves.
Thank you, sir. The honor is ours. I'd like to maybe stay with you, Dr. Shiva, and also go to Dr. Amar as well, and with the same question. Maybe actually we could all consider this question if you like, but if we propel ourselves a year forward and we look back to this Global First program, let's face it hasn't been done before, extremely new technology, FDA approval for the first time in human history in this domain 6 months back, so it's a lot of new stuff. What would you say the main determinants of the success of such a program would be?
That's a great question, Lawrence. So currently the uptake of screening for colorectal cancer is far less than where it needs to be. And I'd like to point out that in the United States, it was only recently where the screening age for screening was lowered from 50 to 45. But the Department of Health in Abu Dhabi and regulators in the UAE have allowed us to screen patients for colorectal cancer in the Emirate of Abu Dhabi for a decade now, starting at the age of 40. And we have countless patients that we have diagnosed with advanced adenomas and early stage cancers that have vastly different outcomes today, thanks to our regulators forward thinking and and working with us in being able to implement these solutions. Now, the way I look at this, Lawrence, is we don't want perfection to be the enemy of good. So any test that advances our ability to screen patients better is better than status quo. And the way I look at how are we going to measure the success of this project is we have data that tells us with our regulators and internally at our facilities what the current uptake for colorectal cancer is. And we hope to be able to move that needle forward significantly before and after, and to be able to demonstrate that we not only are screening more patients, we are diagnosing more early stage and advanced adenomas as opposed to the later stage cancers. So that would probably be the best metric for us, the yardstick for us to measure progress. By no means are we at a perfect stage in screening for colon cancer, but I think with every step, we're moving towards a better future. And I think this project, the first of its kind globally, and again, may I remind the audience, is within 6 short months of the first ever liquid biopsy test being approved in the US and worldwide. Here we are talking about offering this project on a population scale. I think it's truly remarkable. And I think we hope to be able to get together at next year's Arab Health at a panel like this to be able to show the results.
Dr. Amar, due to time limitations, I'll just ask you that same question, please, in terms of the levers that you would look back to in a year's time and say, these are the top key levers of success. And then I'll move to our industry partners for a perspective of one of the most difficult parts of this discussion, which is the health economics of the endeavor. So I'm just giving you a bit of a heads up. Dr. Amar.
Sure, thank you. So just briefly, I echo everything that Dr. Shiva has said. So the best test is the test that gets done. I think for us, the success will be that we see these numbers improving, especially with adherence, compliance, diagnosis patient at an earlier stage and saving their lives, and increasing our screening numbers. Again, one more thing to say is it doesn't matter what test you do, you just need to get screened, and that will save lives. So I'll leave it at that. Thank you.
Compliance. Yeah. Mechanisms to promote that compliance.
Compliance.
And an uptake.
Yeah.
Dr. Amir, these tests are not very cheap. Some of them are more expensive than others. Tell us your insights on this journey, on building this successful business, on how strong is the health economic case for liquid biopsy deployment for population level screening programs in your mind today? In your case in the colorectal cancer, if you wish, and then I'll ask Dave if it's okay, the same question to you from your perspective. Thank you.
Thank you for this great question. We believe in order to have a long-term sustainable patient impact, we need to have not just outcome improvement, but health economic improvement, so such saving lives can continue for long term. So we've shown it for our Garden 360 product, when right treatments are getting used, when some unnecessary biopsies are getting avoided. We have publication around it. And now most recently for our cancer screening product and this colorectal cancer screening, we published a health outcome and economic analysis that looked at the cost of patients remaining unscreened versus the cost of utilizing a test like Shield. And actually what we've shown is actually it's effective and it's cost efficient to use this test. It's not just our publication. American Gastroenterology Association also published a paper recently last year that actually did the same thing, that as long as we are focused on unscreened patient population, using a blood test would in fact reduce cost because of late stage cancer management becomes early stage management and so forth. So we are very excited that actually not only we can save lives and improve outcomes, but we can reduce the cost of healthcare by really stage shifting these cancers to earlier stage and curable stage.
Thank you, sir. Dave, in a couple of minutes, because I want to make sure that we have time to close with Dr. Budoor's comments. Please.
The story is similar with pancreatic cancer. Management of stage 3, stage 4 metastatic cancer is very costly. And that's where most of the patients show up with pancreatic cancer. So by being able to detect it at stage 1 and stage 2, there's significant cost savings along with a major reduction in pain and suffering for many individuals and their family members. We've had 2 different cost effectiveness models put together, one here in the UAE, independent from the company, and the conclusion was by focusing on the high risk patients, those are at the highest incidence of developing pancreatic cancer, that it is cost effective for the healthcare system to test those patients.
But Dave, what about that quality adjusted life year piece that was published? Can you just very quickly comment on that? The work towards that quantification of the health economics?
In general, we've had, again, 2 independent models that have been produced to perform that analysis, and both of them were positive, independent. So I think in general, the concept of focusing in on the earlier stage detection of cancer is the right thing to do for the healthcare system in many cases. And of course, more studies will unfold as we move forward, but this is giving the initial traction and in many cases reimbursement approval for these particular tests.
The big success of ClearNote Health is much smaller business than Garden, but you have 2 CPT-coded tests now in the U.S. market, which is a significant success and worth congratulations. I'm going to close with our own Dr. Budoor, and maybe Dr. Budoor, in your closing remarks, if you can share with us a bit on the next, what we refer to here and what the Abu Dhabi Public Health Center refers to as next generation screening, and how we ensure here in Abu Dhabi that new technologies are continuously added to such screening programs. Thank you.
So for next generation screening, they are meaning that FHAS will be moved, and we actually in the transition phase of moving FHAS to next generation screening. And just to define what's next generation screening means that we have to use like different type of technologies and methodologies for early detection and diagnosis of these type of chronic diseases that we mentioned, including cancer, of course, and cardiovascular risk factors, in order to, of course, to lead to accurate and personalized screening outcomes by using these type of technologies. And actually it can simply adding some genetic testing using advanced imaging technologies like reading, also using the AI technology. So AI can be used, for example, in reading mammograms for breast cancer, now reading x-rays also for different type of lung diseases, including cancer. So using also AI, for example, in analyzing different large sets of data for that can improve our screening programs, and the optimal goal, of course, here to enhance the effectiveness and the efficiency of our screening programs that lead to better health outcomes. In terms of how we can integrate all of these type of new technologies to our existing programs, we have to, of course, adapt several strategies to ensure that. And this is what we are doing currently with the collaboration of our stakeholders from M42 and Guardant Health for liquid biopsy. So first of all, we have to encourage the ongoing research for these type of technologies in order to ensure the efficacy and safety of these technologies to be implemented on the ground. Additionally, it's very important to have clear regulatory frameworks and pathways for our healthcare providers. So once they start implementing these type of technologies within the screening programs, it will be very clear for them to ensure the smoothly implementation of these technologies. In addition to that, our, of course, healthcare providers, they have to receive training and educations, and they have to be very knowledgeable about these type of new technologies and advanced technologies, because they are the first encounters with the patients. They have to convince those patients to go for these new type of screening. Additionally, we have to also foster the collaboration between healthcare providers, policymakers, researchers, technology companies that offer these type of screenings, because we have to ensure and facilitate the integration of these technology within the existing screening programs. Also, when we come to our population or the community, we have to increase awareness among those population about these the benefits of adopting these new technologies, because we need to encourage them for their participation. This will help us to increase, of course, the screening rates that we are lacking currently. System integration, which is very important step also, and currently we are working on this very closely with our stakeholders for liquid biopsy. So we have different data. We have different data from different sources. We have to ensure that we have a clear and a comprehensive overview of those data, so we can translate it into the patient a clear picture, so we can encourage and we have a better outcomes for our patients. At the end, all of these things, if it is ready and on place, we have to pilot our program, and currently we are piloting our liquid biopsy program. So we have to ensure that the feasibility and the impact of these implementation of this type of screening programs will lead to a better health outcome for our patients.
Thank you, Dr. Budoor. I've been in the health innovation space for a few years. One of the things that people say in conferences are generally, health technologists or innovation people and scientists and clinicians are very well aware of, is that often technology is way ahead of policy making, and that is a big pain in the system, because policy making is it takes a lot of time to catch up and enable that technology. I think I'm extremely proud to be able to introduce these panelists today, because I think we're proving that in the Emirates, this policy making is kind of almost at the same speed, or if not a bit before it. So please join me in a very warm round of applause to thank our panelists today, and thank you very much for joining us today.